Our next speaker is Professor Lars Aabakken. He's currently the Professor of Medicine and Chief of GI Endoscopy at the Oslo University Hospital in Norway. Lars has many posts, and he's currently the editor-in-chief of the Scandinavian Journal of Gastroenterology and the chairperson to WEO activities to reach Africa. So in short, WARA, and he's also a member to the EU medical device panel and so on. So we've known him as a brilliant endoscopist, and he's coming to give a speech on assessment of biliary strictures.
Well, thank you, and thank you so much for inviting me to this distinguished arrangement and meeting. And I communicated with my good friend Peter Cotton last night, and he expressly told me to give his best regards to the team here. These are my disclosures, and I will discuss briefly biliary strictures, which can be looked upon in a variety of angles. So asymptomatic strictures are obviously dealt with differently than the symptomatic ones, and with the increasing number of cross-sectional imaging for all sorts of symptoms, we not infrequently find these asymptomatic strictures which may have no significance at all. We can look at it as diagnosed or the indeterminate ones. I'll come back to that. By etiology, of course, whether they're benign or malignant, by location, which also mandates different approaches, and by the treatment plan, whether it's a palliative or a temporary measure. So first, for the diagnosis of strictures, ERCP is certainly not on top of the list, because most of these patients will have a CT scan or an MRI or a PET or a combination of those. It's usually a part of the diagnostic workup, and most extrinsic processes causing a stricture will show up on this imaging. And for the ductal appearance, while this was initially the utility of ERCP, this is now almost completely replaced by MRCP, although there are pitfalls, not least vascular structures imitating strictures. But I think because we increasingly need tissue diagnosis, that has sort of reclaimed a role for diagnostic ERCP as well, not for imaging, but for sampling. So this would be the classical malignant compression stricture, and if you have this CT scan, there is no doubt, I think, about the mechanism. And these are the imaging seen by ERCP or MRCP, where the cause may not be as clear. But mostly those external compression from tumors are not a difficult diagnosis. The post-surgical strictures we see at least from complicated laparoscopic cholecystectomies, and usually the diagnostic workup is easier in these cases. So we have the early postoperative jaundice patients caused by failed clippings or suturings or other kinds of technical mishaps, or the later jaundice caused mostly by ischemic injury. And in these cases also, the non-ERCP based imaging is critical, not least because non-passable strictures post-operatively give a very poor ERCP cholangiography. We can miss excluded segments, which are shown by MRCP. And also strictures and leaks may often coincide post-operatively, and those are also better seen with other modalities. I just want to mention as well stone disease, because stone obstruction may mimic biliary strictures clinically as well as ductographically. And stone disease may coincide with strictures as well, because stones may cause strictures, and strictures may cause stones as well. And Maritzi syndrome, although sometimes clear, it's sometimes not so easy. So this is, I think, a clear case of a Maritzi syndrome, but in this case, the ductographic appearance is not as clear. This was also a Maritzi syndrome, but less obvious on the imaging. So that is reasonable to keep in mind as well. I think our problem is the indeterminate strictures, where the accurate history for sure is even more crucial. If some surgery was done in the past, that may have significant, or if there is a history of blunt or even sharp injuries to the region. If the patient has other autoimmune disorders, that might call for diagnostic workup in that direction. And the pattern of pain might indicate stone clinic as well. But remember that the ductal malignancy as the cause of these strictures is a rare disease, and most of the times the cross-sectional imaging will show a mass lesion at the time of diagnosis. And then there is a special case of primary sclerosing cholangitis, and I will come back to that later. But for the diagnosis of these indeterminate strictures, I think ERCP has come back as a diagnostic modality. For many, many years, we have been doing brush cytology. It's still the standard of care, but as you know, the sensitivity is insufficient, ranging from 30 to maybe 60%. And even though we have added the fluorescence imaging as well, which may increase the sensitivity a little bit, it's still not optimal. We can do direct biopsies alongside a guide wire with a normal biopsy forceps, but that's mostly limited to distal strictures. And at least in my unit, we're now looking at ways of utilizing bile aspiration to look for particularly for malignancy markers. And I think these methylation studies are developing rapidly, so hopefully this may be a guide also in the future. And then there is cholangioscopy guided visual sampling directly. And I think for these indeterminate strictures, cholangioscopy has increasingly shown its value. And that's by the combination of a visual assessment and the directed biopsies available, and not least now with the new SpyBite Max forceps. I think for de novo cholangiocarcinomas, this is an excellent modality, which mostly will give you the diagnosis. I think in the cholangiocarcinomas developing in the context of PSC, it's more difficult. The navigation of the cholangioscope in the narrow and fibrotic ducts of PSC patients is more difficult. And I also think that distinguishing inflammation from dysplasia, from malignancy, is a lot harder. So I still think we have a way to go before we can define the role of cholangioscopy in those patients. And I think also, although we do a visual assessment, I think the knowledge and the competence in assessing the visual appearance is still incomplete, not least because many of these patients already had a stent in place as an sort of initial treatment, and the effects of stenting on the visual aspect is still not quite clear. We're hoping that the AI may aid us eventually on the imaging assessment, but I think compared to the teaching material, for example, of polyps, where we have hundreds of thousands of imagings available, the material for teaching is a lot less in this field, so it will probably take longer to teach our AI machines. This is one case of a surgical patients being assessed for surgery. And as you can see, these are the right-sided normal intrahepatic ducts. But as we pull back towards the liver hilum, you will soon appreciate the problem of this patient, because this is the hilum here, and on the left side you have these tumor changes. So I think it's very obvious from this video that you can appreciate the tissue where you need to biopsy, but you can also very, very distinctly delineate the extension of the tumor, which is extremely helpful for the surgeons planning resective surgery. I just want to mention PSC specifically because this is a very common disease, particularly in the Scandinavian countries. And the diagnosis may be clear, but sometimes not so clear. And different from most of the other liver diseases, cholangiography is the #1 basis for calling this diagnosis. In the past, ERCP was the gold standard here. But even though the MRCP imaging is less clear, most of the time the diagnosis can still be made based on these images, not really needing the ERCP for the diagnosis per se. And this is also included in a recent guideline from the ESGE, calling for MRCP as the main modality for diagnosis. Now, for the endoscopic handling of these strictures, it's 3 components: access to the strictures, and then treatment by dilation or by stenting. And just for access, I just wanted to show you this video, which is not so uncommon. So this is a postoperative duct-to-duct anastomosis stricture. And there is, even though we get contrast past it, it's very hard to find the orifice, partially because there are 1 or even 2 cystic duct remnants in the level of the anastomosis. And so in some of these cases, increasingly, we also utilize the cholangioscopic access, and I'll show you why that makes sense in these cases, because typically we will just probe and reprobe with our guide wire, and sometimes never find the orifice. So here, if we try that hole, that's one of the cystic duct remnants, which is where the wire is most likely to go. And then the real anastomosis is down here. And I think you can appreciate that if you just sort of stochastically probe with your wire blindly, you may never hit that little hole. So I think in these cases of anastomotic strictures, increasingly we are helped by cholangioscopic assessment and access. So once you are inside the stricture, there are some other additional considerations needed. So in some cases, the diagnosis is already clear. Otherwise, you should always consider a brush cytology or other sampling as a part of your procedure. And then you have to decide whether you want to dilate or stent. We'll come back to that. Whether you want to place multiple wires before starting your stenting, and whether you want to dilate as well. Sometimes you skip the dilation and then you are sorry afterwards because you're not able to pass your 2nd or 3rd stent. You have to decide on the caliber for your dilation if you want to dilate, and you have to make a choice for stenting, the type and the duration. So plastic stents are still our primary tool, I would say, for hilar and intrahepatic strictures. And also for some extrahepatic strictures very close to the hilum, where placement of metallic stents is a challenge. I think at least in our unit, we increasingly use pigtail stents. And for caliber, for fibrotic strictures, multiple stenting is for sure relevant. For malignancy, not so much. In those cases, we usually just place 1. So for malignancies, we never do programmatic exchange of plastic stents because the duration of them is so variable, and in the occasional patient, they can last 6 months or more. So we never take these patients back for programmed stent exchange. Metal stents increasingly are utilized, as you know, mostly because of the caliber. The deployment is usually a lot easier than plastic stents because of their excellent pushability. And we hardly ever use non-covered stents anymore because the covered stents cause the concerns of the covered stents, which have been pancreatitis or cholecystitis, are quite rarely seen, and at least in the context of strictures, dislocation of the stents are also quite rare. So the rule of thumb for us anyway is that we use a covered SEMS for extrahepatic strictures unless they're so close to the hilum that we're unable to get the sort of upstream expansion of the stents. While for the hilar and intrahepatic strictures, we mostly use plastic stents except in some select cases. Just a few words on the specifics of stricture types. I think I'll skip this. But for the surgical strictures, these we have the immediate strictures, the immediate complications, as I said, and then the late strictures, and then the therapeutic principles would be for the early ones to manipulate carefully because we don't want to harm the tissue more. For the fibrotic strictures, we usually have to stent them. We can try to balloon dilate, but it's mostly insufficient. And we use metal stenting, but in some cases, the upstream caliber, at least shortly after surgery, is quite limited, different from a malignant stricture. And so the caliber, the 10 millimeter caliber, can be sometimes harmful. For hepaticojejunostomies, we also not infrequently see problems. And this is one such patient where we have to navigate across the enteroanastomosis, and then look for the hepaticojejunostomy at the top of the roux limb. And you can see there is something surgical having been done here, but there's really no orifice to see at all. So then, since I'm showing you this video, we were able to find the orifice, but it was really almost invisible. In some of these cases, we use a needle, an injection needle, if we can appreciate exactly where the orifice is, and then inject contrast to see that we actually have contact with the ducts before accessing with a guide wire and a needle knife. And then in this case, we mostly do balloon dilation, not to have to go back and remove a stent later on. Just a few words on PSC strictures to finish off. The dominant strictures are an important part of this disease, and endoscopic therapy has been shown to delay the time to transplantation. And then the question is whether we stent them or balloon dilate or even both. And we published in a couple of years ago this study, which was the first randomized comparison between the two modalities, where we compared 2 weeks short-term plastic stenting with balloon dilation. And we randomized 60-something patients. And then there was an interim analysis where we saw that the effect was actually comparable between the two modalities, but the frequency of pancreatitis was a lot higher in the stent group. So the conclusion of the study was that probably in these patients, at least for the initial attempt, balloon dilation should be preferred. I have not been speaking about the role of EUS here, but obviously there is such a role, partially diagnostically, primarily for external tumor compression, of course. For the cholangiocarcinomas, I think the role is less clear, and in patients who may be transplant candidates, we worry a lot about tumor seeding. So I think at the moment, for cholangiocarcinomas, we prefer still ERCP-based sampling. And then there are therapeutic options as well, which has been covered by other speakers. So to conclude, biliary strictures do pose diagnostic as well as therapeutic challenges, and ERCP has become a diagnostic modality again for the sampling options. And Spyglass has advanced our diagnostic capacities, also, although we still do not have all the answers. Endoscopic therapy is successful as final therapy, but also as palliation. And we obviously need to keep closely connected to our hepatologists, oncologists, radiologists, and surgeons to add to the quality of life for the patients and also for ourselves. Thank you for your attention.
Thank you so much, Lars, and I think it's a wonderful lecture. So any question from the floor? So, Lars, may I ask, sorry. So if you are going to assess and differentiate between the benign or malignant stricture, as you mentioned, that cholangioscopy is one of the methods. While, do you think that from just advanced imaging, you can actually differentiate, or you always need to take a biopsy to differentiate? And how would that affect your management?
Well, that's an excellent question, and I think we're still, this is, like I mentioned, work in progress. We sometimes see changes which we think very much look like cancer, and there are some obvious features which make that quite clear. But like I said, for example, the effects of stenting are sometimes not quite clear. And I think some inflammatory changes as well can mimic cancer. So at the moment, similar to what we think about other lesions, I think at the moment we rely primarily on the biopsies. And then over time, probably we'll get better at assessing the visual aspects as well. But at the moment, I would be very careful to coin a malignancy based on the visual appearance alone.
Thank you so much.